This talk is a combination of intracellular Doppler spectroscopy combined with deep learning in clinical trials, and the goal is to personalize cancer chemotherapy. So first I'll describe how we develop dynamic contrast and digital holographic full-frame OCT, and then describe several clinical trials for therapy guidance, and in particular what we're looking for is chemoresistance, when we can direct patients again away from ineffective treatment. And then I'll describe a deep twin, also known as a Siamese twin, neural net classifier. So most standard of care chemotherapies are what are known as cytotoxic. So almost all patients get cytotoxic therapy before going to either targeted therapy or immunotherapy. And yet 30% of patients receive no benefit. For instance, if it's in a neoadjuvant setting where they get the chemotherapy before surgery, in fact, the tumor can keep growing. And so we'd like to direct patients away from that ineffective treatment and they could go straight to surgery. Also want to point out that all patients suffer from the toxic side effects. And so not only might the tumor still be growing, but the patient is suffering the side effects. We need to avoid that. So there is this pressing need to direct patients away from ineffective treatments. And it does more than just improve the quality of life of the patient. It also reduces cost to the patient as well as cost to the healthcare system. So we've been doing dynamic contrast in OCT for about 15 years now, actually. And so we first developed this, it was digital holography, and it is en face or full frame. And so what we do is we work with a low coherence light source, and it's split in a Mach-Zehnder. So this looks a lot like a time domain OCT system, but in fact, what we're doing is an off-axis digital holography so that we're doing spatial heterodyne instead of temporal heterodyne. And so for that reason, the reference arm is actually static. For a given depth inside of our target, we've got a static reference arm, and we do holography at a fixed coherence gate inside the sample. And then by moving the delay stage, we then push through to additional depths. So we work with our hologram on a Fourier plane. So it's a Fourier domain hologram. And so this is a blow up here with these interference fringes. Then we do a numerical Fourier transform, take us to our image plane. And so then we've got the two sidebands. We isolate one of the sidebands, and then that is the optical cross-section at some depth inside of the target. And then because the target's alive, this speckle is dynamic, and so we take movies. And we'll take about 2,000 frames at 25 frames per second. And so at each pixel, we've got a time series of intensities, and so we can then do spectroscopy on that. So this is dynamic contrast in dynamic holographic OCT. It's en face, and so at a fixed coherence gate, here we have the coherence gate at the top of the tumor spheroid. So this is a target. It's grown in a bioreactor. It's about 1 millimeter in diameter. And so here the coherence gate is right at the top. The color is color-coded on dynamic activity. And so it's how much proliferation is going on. And so here we are at the top. We're pushing the coherence gate down. This is roughly the midsection of the tumor spheroid. Now, it's a large tumor spheroid, so it has a hypoxic and actually a necrotic core where the cells are dead. They're not proliferating. And in fact, we have very low activity in the core. And so we can see the shell, the outer shell of proliferating cells. We push our coherence gate down to the bottom. We can do a three-dimensional reconstruction. And then this was the first time that dynamic contrast was done in OCT, and this was done in 2007. But we want to do more than just look at how much activity is going on. We'd like to do spectroscopy. Inside the cells, everything is moving with different speeds, and those different speeds, when they scatter light, are going to produce different Doppler frequencies. So we do Doppler spectroscopy, and it's just dynamic light scattering, but the reason why it's Doppler, and you can go to our publications, but it's Doppler because the motion inside a living tissue is persistent. And so the persistence length is much larger than a reduced wavelength. And so it turns out that we really are in the Doppler regime. So even though it has this, what most people in DLS, dynamic light scattering, would call a diffusive knee, it's actually active transport in a Doppler regime. It's just that it's isotropic. And so the isotropic Doppler scattering produces this thing that looks like a diffusive knee. So we start with an initial spectrum, and this is actually on a log scale on the vertical here. And so this is 3 decades of vertical dynamic range. And then we have also 3 decades of frequency range going from 10 millihertz up to 10 hertz. And then we apply a drug, and then you look at the final spectral density, and there's a change. Now, because this is log-log, these changes can be relatively large. They can be 30, 40, 50%. And so we capture that in a drug response spectrogram. So this is colchicine acting on a DLD1 tumor spheroid, and we have, in this case, we've converted frequency to intracellular speed. So 10 millihertz is actually about 3 nanometers per second. 10 hertz is about 3 microns per second. So we've got 3 decades across the horizontal axis. This is time on the vertical axis. We apply about a 4-hour baseline before applying the drug. And this establishes the spectral shape. Then we apply the drug and we look at the changes in the spectral shape. So in this case, we have an enhancement at low frequencies, suppression in mid frequencies, enhancement at high frequencies. Vincristine, so this is a cytoskeletal drug. Vincristine is also a cytoskeletal drug. Very different signature. Also a very different tissue type. And so we build libraries of drugs and tissue types. And what we can do is then look for the response of the tissue to a drug to assess whether the drug has, or the tissue has, drug resistance. Now, before I talk about the cancer chemoresistance work, I do want to just highlight just a couple of very recent developments that we've made in this dynamic contrast. One is visualizing heterogeneous drug responses. So rather than averaging over the entire tumor, which is what I was showing in the previous slide, you can do spectroscopy spatially mapping the spectroscopy across the tumor as it responds to drugs. So we can look at different frequency contents. We can create these multicolor merges. And you can see, and this is just a collage, these are esophageal samples from a human patient. And these are responding to different drugs, and these are different frequency responses, lots of heterogeneity. And heterogeneity is one of the key problems with chemoresistance. You might have a part of the tumor that is responding to a drug, but other parts of the tumor are not responding to the drug. And you have to know how much of the tumor is actually responding and how it's responding. And we've also done a recent study in which we compare this TDSI, tissue dynamic spectroscopic imaging. We compare that against actual histology. Another recent development is phase-sensitive dynamic contrast. This is where we extract the phase, and we can do fringe tracking, which then allows us in our spectroscopy to get actual Doppler peaks. And so these are objects that are moving with 3 different speeds, and so we get 3 very nice Doppler peaks here. Now, in living tissue, you don't get Doppler peaks, but you get a Doppler knee. And then if you do phase spectroscopy, which is in this paper just published this year, you find that, in fact, the best fit to the phase histogram is actually a Levy distribution. It's not a Gaussian, it's not a Cauchy, it's actually a Levy distribution, which raises the possibility that there are actually Levy walks going on inside of living tissue. And then a third recent development, again published this year, this is where we're monitoring bacterial infection using dynamic contrast. And this is where we take a tumor spheroid grown in a bioreactor, and then we expose it. We infect it with E. coli, Listeria, Salmonella, and we can watch the progression of the infections. And most importantly, we can look for resistance. This is a case where we have an E. coli, which is resistant to ampicillin, and you see that it keeps growing. So the ampicillin was applied here. Whereas here the E. coli does respond to ciprofloxacin, and then you can see that it reverts back to its original state. And so we can use this as a way of testing for antibiotic resistance. But the main point of the talk today is to talk about personalized cancer care. So it's actually a fairly simple technique. I mean, what we do is we take biopsies from a living human patient. We break it up into about 72 pieces. That goes into a 96-well plate. And then we apply a lot of different drugs and combinations. These are all standard of care or FDA-approved drugs, but we're looking for the drugs that produce the best responses. And so we're looking for 3-dimensional physiological responses. These are called phenotypic responses. And we'll have a lot of degrees of freedom, and so we'll use deep learning. And so we'll put this into a deep twin or a Siamese twin neural net. So this is an overview of one of our clinical trials. This is esophageal cancer. We enrolled 25 patients. 14 of them were resistant to their platinum-based therapy. 11 were sensitive. These are the different drugs: carboplatin, cisplatin, Taxol, 5-FU, and then also the combinations. And in fact, the patients get the combinations. So these spectrograms at the top here, these are for resistant patients. It's the average, and then this is the average overall, the sensitive patients. And you can just see with your eye, if you look at the combo carboplatin plus Taxol between the resistant and the sensitive patient, there's a very distinct difference in signature. And so what we do is we actually take these spectrograms, we break them up into features, and I just want to point out that when you consider the number of patients, number of wells per patient, number of features per well, we have about 59,200 features that then really demands deep learning to use that to classify whether a patient is sensitive or resistant to their chemotherapy. So this is the data flow. We start with the 96 well plate with drug replicates. That goes into these feature vectors. We do random selection with replacement in a process known as bootstrap aggregating or bagging. And so we create these patient bags in which we have different drugs in each row here, and then we have the features coming along, the different columns. And so we'll have about 301 features per bag. We'll have 43 bags per patient, and that gives about a 4x coverage for each drug on each patient. And then that is the data that goes into both sides of the twin neural net. So this is a deep twin or a Siamese twin neural net. So these neural nets are identical. They have 3 hidden layers and with a low dimensionally output layer. And they'll get data that are either from the same class or from different classes. So the label that we use is either 1 or 0. 1 if they're from the same class, 0 if they're from different classes. So you don't actually have to have distinct class labels. You just have to know whether the samples going into the twin network are the same class or different classes. And then we use Euclidean distance, and we have a contrastive loss function, which we minimize. And so we minimize the distance if they're from similar classes. We maximize the distance if they're from dissimilar classes. And that produces a low dimensional clustering that you can then use for classification. And so then this is looking at the neural weights. As I mentioned, this is deep learning. And so we have 3 hidden layers. We have 225 input channels, 128 hidden neurons in the first layer, 32 in the second layer, 3 in the third layer. Our output space is 3-dimensional, and so the 3 output or neurons produce the final outputs. After training, we do get the clustering, and so these are 3 classes that cluster very nicely apart, and then those go into a classification and then lead to a confusion matrix. So for clinical trials and for clinical utility, I do want to talk a little bit about the confusion matrix. It's not just a matter of getting the diagonals high and the off diagonals low. What's important is for instance, if you're doing neoadjuvant chemotherapy, this is where they get chemotherapy before going to surgery. But if the chemotherapy is not working, you'd like them to go directly to surgery. What that means is you need to get this top row right. And so you want to have a very high true positive on the top row and very low false positives on this top row. The overall accuracy doesn't matter so much. You might actually misclassify a partial response for a complete or a complete for a partial, but what's important is that when you say that someone is resistant, that they truly are resistant, and then you direct them away from that ineffective treatment directly to surgery. And so that's what produces what's known, the metric that captures that is known as the positive likelihood ratio. And there's a clinical standard that if your PLR is greater than 10, then your diagnostic assay has clinical utility and you really can direct the patient away from this therapy and to a better therapy. And so this now is the status of our 3 human clinical trials. So there's 3 cancers: esophageal cancer, muscle invasive bladder cancer, triple negative breast cancer. The patient numbers are 25, 31, and 37. Overall accuracies go from 84% to 92%, but I mentioned that the overall accuracy isn't as important as the positive likelihood ratio. And in fact, in all cases, our PLR is greater than 10 to 1. So in fact, we have clinical utility for each of these 3 pretty small pilot trials, and yet we've already have clinical utility and statistical significance in these trials. Now, these are all done retrospectively, and so these accuracies are done with cross-validation. We actually use holdout cross-validation. We also regularize the training and the classifiers, but the next step is to do a prospective blinded component of each of these studies. And this is where we use our trained network, and then we have blinded patients, and then we predict those, and then we see what our overall accuracy and most importantly what our positive likelihood ratio will be in a prospective case. But that's actually still to come. And so I'd like to thank our funding agencies, NSF, NIH, and all the people who have done the work, and also thank you to the audience.